Welcome, everyone. I'm Carmen Pugliafito, and I'm here today with Dr. Thomas Albini, who is professor of clinical ophthalmology at the University of Miami Miller School of Medicine, Bascom Palmer Eye Institute. Welcome to Retina Synthesis, Tom.
Thanks for having me, Carmen. I'm really looking forward to this.
We're going to talk about retinal vasculitis. It's a disorder which is not commonly encountered by the average retinal clinician. And we'd like to update our audience about the clinical manifestations, etiology, diagnostic evaluation, and current clinical management of this disorder or disorders. How do you define retinal vasculitis?
Well, I think it's a finding on fluorescein angiography is really the way that we've defined it over the years. And it's different from the definition that you have of a classic vasculitis as the rheumatology text talks about, where they have histology. And it's a fine point, but there is a difference between the inflammation seen around vessels, arteries, veins, capillaries, smaller vessels, as has been classically defined in conditions like Behçet's disease or polyangiitis and other disorders, lupus, as has been classically defined by histology and what we see in the eye. In the eye, we don't have the luxury of having a histologic diagnosis, but it's a diagnosis based on seeing extravasation of fluid from the retinal vessels. And those are often associated with inflammatory infiltrates, but they may also be just leakage of fluid. You have to keep that in mind, that what we're seeing on the fluorescein angiogram is leakage and some staining of the cuffing and the perivascular infiltrate that you see. So what we're often looking at is inflammation right around the vessels. And so that's how I would define it. And as you said, it's seen in a myriad of conditions, in autoimmune conditions, in infectious conditions, and in some neoplastic masquerade syndromes. You have to worry about it. So it's a very difficult thing to make the correct diagnosis, and many things that need to be ruled out or need to be thought of that can present with retinal vasculitis. Another really important thing to say right off the bat is that we don't do that many angiograms anymore. So I wanted to start talking about fluorescein angiography, but the reality is that in busy retina clinics nowadays, OCT is the imaging modality most often employed. And the type of leakage that you see on a fluorescein angiogram isn't really seen very well on an OCT angiogram. And unless you're employing fluorescein, you may miss retinal vasculitis. You may see an inflamed eye and not know that they have vasculitis. And then recently we had the occurrence of occlusive retinal vasculitis, rarely after the use of a novel anti-VEGF agent, after bevacizumab hit the market. And so many of us were so excited to have this, what seemed to be a really great drying agent, possibly better than all the other agents that we had. But in a very small number of cases, patients would develop this occlusive retinal vasculitis. And unless you performed an angiogram, you could totally miss that. So anyway, just to put in a plug there, but in terms of the diagnosis and the evaluation, angiography, I think, is still essential, and it's something that a lot of people don't even have in all of their offices anymore.
What's the ophthalmic appearance of retinal vasculitis? What are the associated retinal findings?
So on clinical exam, I'd start by saying, because it's often an inflammatory or infectious disorder, you'll see an inflamed eye, including all the other sequelae of inflammation, anterior chamber cell, vitreous cell, cystoid macular edema, chorioretinal lesions. I mean, that's the setting in which it happens, not exclusively. Sometimes you won't have any of those things, but those would be things I would look for. In terms of the actual vessels, you can see cuffing or sheathing. You can see infiltrates around the vessels. You can see sometimes more elaborate infiltrates coming off, like in the candle wax dripping, classic presentation of sarcoidosis, for example, which often manifests as a retinal vasculitis. Sometimes the vessels just look engorged, like in birdshot. You can get vasculitis right off the primary vessels coming off the optic nerve. They can be engorged, and when you do a fluorescein angiogram, you'll see that they're leaking. Sometimes you can see, the sequelae of ischemia, hemorrhages in the retina around the vessels. But I think those would be the main findings, and then you can confirm them with an FA.
So, diagnostic evaluation of the patient. Let's talk about imaging. You emphasized the importance of fluorescein angiography of being almost a unique tool for making this diagnosis. But what about wide field angiography? What about indocyanine green angiography? Other imaging techniques?
I think that indocyanine green angiography is important for select conditions and looking in general for choroidal involvement, because you can see the lesions that we think are deeper in the choroid, like in birdshot chorioretinopathy, or in sarcoid. You can see sarcoid granulomas very nicely on ICG angiography. I think interpreting, better than I do, because I've read your book on ICG angiography, but I think vascular leakage on ICG is more difficult to interpret than some of the hypocyanescent lesions that you have. But I think that the way I use ICG is specifically if I have a diagnosis in mind, like birdshot or sarcoidosis, I will use the ICG to confirm that diagnosis, looking for those findings. In terms of wide field angiography, I think that's really, as far as I can tell, I mean, in my hands, that's the norm. I have a photographer who's trying to get certified for some clinical trial, and she has to do, I won't mention the system, but she has to do a non-wide field system. And I realize how painful it is for me to recommend to her to use non-wide field angiography on any of my patients, because it's just so much harder to interpret. So I think the wide field system, we use the Opto system for both fluorescein and ICG, is just fantastic, and is really easy to make a decision as you're following the patient through treatment. If they're getting better or if they're getting worse, it's just so easy to line up those pictures. Whereas in the old system, with the limited view and the smaller pictures, so you don't always get the same spots, and unless you have a really good photographer. And again, we're doing less angiography, so they're not getting better at it. It's sometimes challenging to get the same spots and make a decision about some peripheral vasculitis. So I think wide field angiography is absolutely essential.
Let's talk about presentation and etiologies. What are the most common etiologies of retinal vasculitis?
I think I see a lot of intermediate uveitis with retinal vasculitis. That's a component of it, usually more peripheral, although there's some patients who have vitritis and a lot of vasculitis going back into the towards the macula, or in the macula even. And you worry about things like multiple sclerosis in those patients, certainly sarcoidosis can present. But I think those are common. When you see those patients, you have to think about a lot of infectious etiologies also. So I think as a rule number one of uveitis is rule out the infections before you start treating patients with steroids. So syphilis can present as a isolated retinal vasculitis or vasculitis with other components, other findings in syphilis. Typically, there's vitritis and infiltrates pre-retinal or even in the retina. So syphilis testing, super easy to get. Some people are squeamish about it. I see a lot of doctors in the community not get it for whatever the reason is. But I think really any inflamed eye, unless it's painfully obvious what's going on, syphilis needs to be ruled out, and you could easily miss it. Some people have it for decades without realizing that they've been exposed to it. TB is a thought, not so much in Miami or in the United States in general, but you don't want to forget about it. And quantiferon testing, if you're going to be putting patients on immunosuppressives, is a good idea anyway. So serology for TB is a good thing. And then think about toxoplasmosis. You know, toxo is an incredibly common condition, cause of a posterior segment inflammation, and it can present with inflamed vessels, with the classic presentation being the Kyrillus plaques that you can see in those vessels. So you need to think about that if you're seeing that type of vascular change. But I do think that the non-infectious causes are more common. And another infectious cause that absolutely can't be missed is viral etiologies. Acute retinal necrosis, CMV retinitis, can present with inflamed vessels. CMV, the first thing that gets inflamed, as Narsingh Rao showed so nicely decades ago, is the endothelium in the vessels, and then the retina gets inflamed subsequent to that. And so it can present first as a vasculitis, either a full-blown frosted branch type presentation that you can see in CMV, or just a more subtle vasculitis. So think about those infections; those need to be ruled out. Look for retinal whitening associated with it, of course, and think about getting a PCR if you're suspicious of any viral etiology. And probably treat for it if you're suspicious of it. To treat with Valtrex is not such a big deal, even Valside, for a short period of time until you get your PCR results back. Better that than to miss it, because those eyes can go south very quickly. And then, you know, I think other etiologies, I mentioned sarcoidosis. You think about Behçet's disease. Almost all patients with Behçet's disease will have ulceration of either oral ulcers or genital ulcers. So important to ask about that. That can really make a diagnosis there. Polyangiitis, the former Wegener's disease, ANCA positive vasculitis is something to think about, especially in patients who present with other pulmonary or renal issues going on, that you can put the diagnosis together and get the laboratory workup for that, or have them evaluated by a rheumatologist that's working with you if they have those conditions, to see if that might explain all of the things that are going on in those patients. Multiple sclerosis, I think I mentioned already, presents as intermediate uveitis. One thing to worry about with MS is that the anti-TNF agents, which we sometimes use for chronic treatment, can make MS worse. So that's something that all patients that present with an intermediate uveitis where I'm considering using MS, I'll get a brain MRI just to make sure that there's no evidence of MS, even if they don't have any symptoms. But otherwise, I ask about neurologic symptoms to see if they have anything going on that could be consistent with multiple sclerosis. And then you get into like uncommon things: Churg-Strauss syndrome, patients with asthma and hypereosinophilia and retinal vasculitis. Ocular conditions, birdshot, sometimes birdshot without the classic birdshot lesions. Or I think we should call it birdshot. I guess it's somewhat debatable. I think some of the recent sun classification work that came out supports the idea that if you have, there are definitely patients like this, they'll present with findings of birdshot, cystoid macular edema, maybe, doesn't have to be there. Retinal vasculitis, maybe, doesn't have to be there. But if you pick up those things, older patient presenting with vitritis and with, let's say, retinal vasculitis, especially, and it really is so commonly this vasculitis, you get the retinal vasculitis you get in birdshot is those primary vessels coming off the nerve. They often look engorged, very symmetric between the two eyes. You get an ICG on that patient, and you'll see those 100 of birdshot lesions on ICG. Now, 90% of the time, 95, I don't know what it is, 95% of the time, you'll see the classic birdshot lesions, those lesions emanating from the optic disc, usually seen more prominently in the infranasal quadrants, seen throughout the fundus. But occasionally you won't, but you'll see the ICG findings and you'll see the retinal vasculitis. And then when you confirm with an HLA-A29 test, those will come back positive. I think those patients should be treated like birdshot, even if they don't have the classic birdshot lesions. So going through Irvan is another fascinating disease, first described by Don Gass here in Miami. And these patients present with neuroretinitis leakage at the optic nerve. And the real sine qua non of that condition is these macroaneurysmic changes seen at the bifurcation of vessels. And still a condition we don't really understand. I have not treated it that many times, but if you look in the literature, you can see it doesn't often respond very well to steroids. It's thought to be an inflammatory condition. Some people think it might not be. The other interesting thing is often associated with a lot of lipid exudates, which is different from other vasculitic conditions that we see. So it's a little bit of a mystery condition, but it's usually treated as a inflammatory disorder. I think those are, the major conditions I would talk about. There's a whole long list of infectious conditions that can present with the retinal vasculitis that are uncommon, but I think toxo, syphilis, those would be and the viral etiologies, those would be the big ones I would think about.
Can you say a little bit about PCR as a diagnostic test?
So important, such a huge benefit to the field. And the biggest complaint I have about PCR is for the life of me, I can't figure out why we don't have more efficient PCR testing directed towards ocular samples. There must not be a market. It must be a problem in the business plan because the science is there. But we do PCRs here. They're single tests. You send out a sample for HSV, a separate sample for VZV, a separate sample for toxoplasmosis. As we do this PCR testing, we're finding that sometimes conditions that we weren't able to diagnose, really bizarre manifestations of toxo, the retinitis type of manifestation you can see in toxoplasmosis, particularly in immunosuppressed patients, but also sometimes in immunocompetent patients. You can miss unless you have the PCR. CMV can present looking like ARN. I mean, the classic teaching we all know is that if you see a CMV patient, there's a clear view to the retinitis because there's no vitritis because they're immunocompromised. That's the AIDS type of CMV, but you can get CMV in elderly patients who are maybe minimally compromised diabetics, something like that. Very uncommon, but those patients can have a CMV retinitis that looks like an ARN because they have a prominent vitritis. And so that'll throw you into thinking that it's more likely to be a VZV or an HSV, and you treat with Valtrex, which doesn't cover it, and ganciclovir and what they really need is ganciclovir, which does cover CMV. And the only way that you can make that distinction reliably is with the PCR. So to me, I would love somebody smarter, more effective than me to come up with a multiplex PCR where you can take a small volume of fluid and do multiple tests. We know what to check for. We could have a geared test for ophthalmology, for uveitis, to look at all these things with a very small volume of fluid. Hopefully somebody comes up with that soon.
Let's talk a bit about therapeutics. Of course, therapy is going to vary widely depending on etiology, but can you give us a therapeutic roadmap?
Yeah, I think like much of uveitis, the number one agent is still steroids, and tend to use systemic, but local steroids work well too. And I'll say more about local steroids later. But classically, you're talking systemic steroids at first, and the reason being nothing works as quickly, nothing is as universally effective as high-dose steroids at controlling inflammation, including retinal vasculitis. It'll usually respond very well. Of course, we're excluding all the infectious etiologies, which need the appropriate, antibiotic, antiviral, whatever it is. But assuming that it's non-infectious, steroids are the way to start. Problem, of course, with steroids is side effects. So the American College of Rheumatology recommends that patients be down to a dose of 7.5 milligrams or less after 2 months of treatment. That's a little hard sometimes, 2 to 3 months. We kind of fudge that rule practically, but by 3 months, I think we really want to get down to that. Now, if that's often, you can't do that without having a recurrence in the inflammation. And there are some conditions for which we know you won't succeed, for example, birdshot, and Wegener's granulomatosis, sympathetic ophthalmia, other inflammatory conditions. You need to start a steroid-sparing agent soon so that you can taper off the steroids without exposing the eye to more tissue damage from inflammation. And those steroid-sparing agents really haven't changed from the time that I started doing this 15 years ago. You're still talking about Cellcept, about methotrexate, about azathioprine. The addition now is the only FDA-approved drug for posterior segment inflammatory disease that's systemic, and that's adalimumab or Humira. And that works nicely. I think most people are still using the conventional antimetabolites as first-line agents. There's some role for T-cell inhibitors. Cyclosporin and tacrolimus still used. So those agents, and the choices are made really looking at patient risk for complications for the different agents. And otherwise, we don't really have a great algorithm of exactly which agent to start with. In fact, one prospective randomized trial that looked at methotrexate versus Cellcept, the feeling was amongst uveitis patient specialists that uveitis was a more profound immunosuppressive agent, but clinical trial couldn't demonstrate any difference between using high-dose methotrexate and high-dose Cellcept in a large variety of uveitic conditions. So now I think we're more in equipoise about which agent to use. And there's a trial, the ADVISE trial, currently enrolling, that's randomizing patients to either conventional immunosuppression or adalimumab. That's an NIH-sponsored trial headed by Doug Jabs. And I'm really looking forward to see the outcomes there, because we really don't know. It may be that conventional immunosuppression is better. It may be that Humira is better. I don't know. I know neither of them work all the time, and they certainly work most of the time. So I don't know if we'll be able to demonstrate a difference. And those are the conventional immunosuppressives. The truth is that the antimetabolites don't really work well for retinal vasculitis. I think the T-cell inhibitors and anti-TNF seem to work a little bit better, but nothing works as well as steroids. And there's a place here, I think, for where vasculitis is really a prominent feature of somebody's inflammation and is not controllable in these other ways, I think that local steroids, especially the sustained delivery products that are out there, Retisert from Bausch and Lomb and Utique, are really great products that release steroids for 3 years and can control both cystoid macular edema. They're great for that, and for retinal vasculitis, they work really well. So those are, I think, our treatment options, either systemic or sustained release steroids. You could treat with serial Ozurdex. I'm not a big fan of that type of treatment because often between the Ozurdexes there's recurrence, and I think that any recurrence predisposes patients towards vision loss in the long run. So I'd rather have a sustained type of treatment than a serial repeat injection treatment.
Well, Tom, thanks so much for this very comprehensive review of retinal vasculitis. And I know it's thought-provoking. If our listeners and viewers want to learn more, where should they read?
You know, I think the best sources I can think of are the Foster and Vitale textbook on uveitis. It's got extensive chapters there. There's always a lot to be gained by relooking at Don Gass's book, the newer editions, or the classic editions. I still think there's a lot to be gained by looking at those books. They're amazing. I'm trying to think if there's any other really can't miss literature on the topic, but I think that those are the places I would start.
Good, Tom. Thanks so much.
That was great. Thanks, Carmen.